So as the next speaker, it's a pleasure to introduce Lars Jord, who's based in Lund, Sweden, who is a physician in late effects for very, very many years. He's the founder of PanCare. He has served on the SIOP board for survivorship for quite some time. He's back on the PanCare board, and with this, I gave him the task to really do an introduction to survivorship and long-term follow-up care in 60 minutes, which we could maybe fill out like 3 days. So Lars, thank you very much for taking on this task, and the floor is yours.
Thank you very much, Katrina, and again, Anna, thank you so much for sharing so openly, and you are a brave person, I think. I'm feeling a bit under the weather today, so if that shows, I apologize for that. This is my personal way of introducing you to survivorship, and it might look different if somebody else did it. So there are many ways to address this. And also, I would like to say, if this raises any questions in any one of you, if you think this is something I didn't know, or I need to know more about this, you're welcome to contact me or anyone else in the faculty, or if you have your own contacts at home, don't sit and wonder about things. Please get in contact with someone so we can help you find this out. So this is, of course, the reason why we are seeing late effects, because we have more survivors. And without cure, there will be no late effects. So this is a fact. This looks pretty much the same in most of the countries in Europe. So we get about 350 new cases of childhood cancer in Sweden. We're a country of a little more than 10 million inhabitants. And we have over 65,000 new cancer cases every year in the countries. You can see that it's a very small part of the entire cancer diagnosis that are in children, which is great in many ways, but it also makes it difficult to do research and so on, because the cases are few, and the better results we get, it's even more difficult to sometimes improve treatment, because it's just not enough cases in order to do that. We have over 80% of children and adolescents being 5-year survivors. There are quite a few of former childhood cancer patients in the general population, around 10,000 or a little more than 10,000 in Sweden. We estimate roughly that it's close to 500,000 survivors in Europe, and it's quite a young population. The median age is around 30 years, so most of them are not old people. And roughly you could say that 25% have received treatment where we don't expect to see a lot of complications long term. In half, roughly half, they have received a treatment with a significant risk of long-term complications. So they may require screening, they may require a follow-up that is targeted, which you will hear more about after the break. And then roughly 1 in 4 already has issues, endocrine or others, that they are already under specialist care for that. And having said that they're under specialist care, it's important that if they go to an endocrinologist, that endocrinologist should also know if there's a reason to look at cardiac function, etc. So it's not only one specific organ system or type of organ system that may be affected. If that is the case, then you need to have a broader approach to this. And it's the treatment you got, how old you were when you got it, and where in your body the disease was located that determines your risk. We fear, and I think we see that unfortunately in our late effects clinic in some of the cases, that our survivors will get the same diseases as the rest of us will get, but maybe at an earlier age, maybe more often, and maybe more severely than for the general population. But then here is where the follow-up comes in. And if you have the right follow-up and it's targeted to the correct things at the right time, we should find, or we may find, treat and optimally prevent late complications. For instance, breast cancer screening has already been mentioned if you've received radiotherapy to the chest. And with the correct follow-up, which includes mammography or MRI of the breast at a much earlier age than the general population, these things could be caught in time, treated, and you will not be a statistic in the late mortality or in the late mortality area. And the goal is that every survivor should receive the optimal help they can so they can reach their maximum potential. That potential may be different than it would have been without a cancer and the treatment, but nevertheless, I'm convinced that there is a maximum potential that you can reach, and we should aim to assist that. And it's going to be a different life many times, but that's not the same as saying that it's a bad life. It's a different life. It's different to what it would have been if you hadn't had the cancer, but it doesn't mean that it's going to be a bad life. So the causes of the toxicity is radiotherapy is a big issue for that. We need it a lot of the time in order to have cure. But we also know that the higher the dose and the larger the volume we irradiate and the younger the patient is, increases this risk. Chemotherapy, we know that higher cumulative doses of some specific drugs usually bring a higher risk. But there's a large inter-individual difference that we don't really know much about today, so that everyone who receives a high dose of anthracyclines does not get cardiomyopathy. And there is, of course, the reason behind why it is like that, and we need to know more about that. And combining radiotherapy and chemotherapy is, in many cases, leading to an increased risk of late complications. Genetic predisposition, we know some about that. It can increase the toxicity and also be associated with the cancer itself. Surgery is, of course, obvious if you look at, for instance, amputation for a bone sarcoma. And then novel therapies, immune therapy or targeted therapy, small molecules, etc. We know some of the complications that may occur, but it largely remains to be seen what kind of late complications there will be after this. So it's important to have a structured and targeted follow-up for this. So what are the treatments of diseases that may increase the risk? Allergenic bone marrow transplant, especially if it includes total body irradiation in the conditioning, is a big issue for late complications. CNS tumors, of course, which is obvious because it's a disease that is sitting in a very critical organ. Radiotherapy has already been mentioned. Some of the sarcomas receive quite high doses of different agents, and for some of them, there's also radiotherapy included in the treatment. High cumulative doses of certain chemotherapeutic drugs, for instance, the anthracyclines for cardiomyopathy and cisplatin for ototoxicity are some of those. And then, of course, relapse or refractory disease, which means that you add more treatment to what was already given before. And that is, of course, an additional burden with increased risks of complications. So already a long time ago, 50 years ago, we started to know about late complications due to treatments, and that was based initially on what was called the late effect study group in North America. where giants of pediatric oncology like Giulio D'Angio could show early that there were late effects of cancer treatments. And they found and could see that if you gave certain drugs or irradiated the gonads, there would be infertility. If you irradiate a growing child, there will be hypoplasia in the part that you irradiate. And one way they could see this was when you irradiated Wilms tumor patients to the abdomen, and you included part of the vertebrae in this. The part that you included didn't grow, but the rest of the vertebra grew. So people got bent backs from this. So now we always irradiate the entire vertebra, which will mean that you will not grow there, but at least it's symmetrical. They also showed the role of alkylating agents in development of secondary leukemia, which is most often myelodysplastic syndrome or AML. They could also show us the genetic predisposition like neurofibromatosis, retinoblastoma, and p53 mutations and their connection with cancer. If you irradiate a patient and bone structures are in the field, there is an increased risk of a bone sarcoma developing, and there is a risk of thyroid cancer if you irradiate the neck. You can have endocrine and cognitive effects if you irradiate the brain, which is not so hard to understand. And again, secondary cancer after Hodgkin's disease was shown when it can occur in men also, but mostly we see it in women where radiation to the breast glands in girls increase the risk of developing breast cancer, which means that you should start looking for this at from 25 years of age or at least 8 years after diagnosis. And younger women have more dense breast tissue, so the recommended thing to look at is modality is MRI. So what are the most severe late complications? It's premature mortality. We call it late mortality. Sometimes it's death more than 5 years after diagnosis, but really what it is, it's premature mortality. Second cancers I mentioned, cardiovascular disease, lung disease, endocrine disease, and not to be forgotten, the neurocognitive complications. And all this led to that almost 50 years ago, Giulio D'Angio wrote this paper in Cancer, Pediatric Cancer in Perspective, Cure is Not Enough. And that's very relevant today as well. We are giving treatments today that are different to what was given in the 70s and 80s, but nevertheless, they may, or some of them will have late complications due to this, to the intensity of the treatment. This is a seminal study by Kevin Effinger and colleagues in the Childhood Cancer Survivor Study, where they started to collect treatment data from 1970 to 1986, and since then they have expanded into 1999. They have all the treatment data, and then the comparison is done by questionnaires where they compare the former childhood cancer survivors to their siblings. And what they could show then 15 years ago or even more now, that up to 2/3 had some sort of chronic condition, of which a fourth had a severe or life-threatening condition. And this was then quite elevated compared to siblings. And the issue with this, and I think that holds true today, is that the incidence of these problems increase over time, and it doesn't appear to plateau. So the longer we follow the patients, the more issues we will see. And I think that holds true for us who work in late effects clinic, that somebody you saw 5 years ago and you see them again now, often there has been an addition of other problems. So here are some of the relative risks of a severe or life-threatening or disabling diseases that survivors had compared to their siblings. So you can see that there are quite high relative risks for some of these issues, but then in absolute numbers, that's a different thing. So the risk is elevated, but in absolute numbers, it can be quite less. So here is from the St. Jude Life cohort, looking at, I think it was 168 chronic health conditions. And they could show that over 90% had some sort of late complications. I mean, I'm not saying that it's a fishing expedition, but if you include everything, of course, you will find more. So if you have many chronic health conditions that you're looking at, you will, of course, have a higher percentage of people affected. And these are then community controls that are here in the dotted line. And you have different diseases. Here you can see that all of them have elevated burden of chronic health conditions compared to their community controls. This is showing from the childhood cancer survivor study again, that the risk of these conditions decrease with the more recent the treatment area is, it's less likely that you will have chronic health conditions. But you can also see here, compared to the purple line, which is what is expected, that it is elevated anyway, even if it goes down with more recent treatment periods. Again, from the childhood cancer survivor study, they could see that risk stratified therapy and adaptation of this over time reduced the late morbidity and mortality among those that were treated for standard risk ALL more recently, which is in their case here is a long time ago now, but it was the 90s standard risk therapies. And they argued then that their risk for health-related mortality and second malignancy for standard risk ALL was not different from the general population. So here you can see from the same study the cumulative incidence of late mortality, all cause of them, and this purple line here is relapse or hematopoietic stem cell transplantation for recurrence and health-related causes of death. And here is the standard risk, 90 standard risk leukemia, which is close to the estimate from the population. But still, these issues are elevated for most of the cases. This is from the British Childhood Cancer Survivor Study and their teenage and adult cancer survivor study, which is also more population-based, I would say, than the American CCSS is. And they looked at respiratory mortality. And they could see that there is an increased risk of respiratory death among survivors of CNS tumors in the childhood and adolescent cohort, and in survivors of lung cancer, leukemia, head and neck cancer, and CNS tumors in the young adults, for those over 50. There was evidence of a reduction in the excess mortality over time, with less deaths among those diagnosed more recently. Here is a comparison with late mortality among survivors of childhood cancer in the United States and the United Kingdom. And as you will see in the graphs on the next page, the findings suggest that US survivors may have received more intense regimens and thereby achieved remission and cure more often than the UK survivors, But the cost of this was a higher risk of death from late effects later on. So here it is shown in a graph with that the red line is in United States and the blue line is UK. And you can see that there are less deaths in the US up until you go to around 35 to 40 years after diagnosis, where the curves intersect, and there are more late deaths in the US. And this is shown again in this way, with the blue line being the UK, that the recurrence or progression rate was higher in the UK. But then when you look at second malignant neoplasms, cardiac disease, respiratory disease to some extent, and all other healthcare related causes, the US has higher incidence of these complications. Here is a look at life expectancy of adult survivors of childhood cancer over 3 decades. And we could see that, or they could show that, especially those that received only chemotherapy for the childhood cancer diagnosis, had less reduction in their expected lifetime than those treated earlier, but it's still elevated to the extent that there is a reduced lifespan compared to the general population, especially if radiotherapy was included. Here is a risk again on a study again on the risk of subsequent malignant neoplasms in survivors. And you can see the standard incidence ratio here for British childhood cancer survivor study, the US, Canada survivor study, the Nordic countries, and the Dutch cohort. Here is the figure 1, which is, if this is the case for this line, shows that if you had the same incidence in the survivors that you have in the general population, there would be the standard incidence ratio would be 1, but you can see that it's quite elevated for all of these groups of attained age. There is a difference when you look at absolute excess risk, where the Dutch and the US studies stand out a bit later on, but it's the explanation of the authors is that the British data and the Nordic data goes back to the 40s, which means that these people who had worse diseases succumbed to their disease, and those that survived had a more easily treatable disease, and that explains why these figures are different. Here is a graph that illustrates that for most organ systems, there is an increased risk of a second malignancy the higher dose of radiotherapy that you give, with one exception, which is thyroid cancer, which you can see here in the light blue line. And the reason for this is that with higher doses of radiotherapy, you get a cell kill in the thyroid gland, meaning that if the cells are all dead, they cannot turn into cancer cells. Of course, they will be hypothyroid, and you need to replacement with thyroid hormone. But for the higher doses, there is less risk of thyroid cancer. Here is from the Dutch study DCOG later, showing that the addition, the exposure of doxorubicin not only has potential problems for the heart, but it also increases the risk of solid cancers and breast cancer. And cyclophosphamide, which we most associate with the risk of development of second leukemia, also increases the risk of subsequent sarcomas. So it's important to know that it's an addition of all these different treatments, of course, with an individual variation, but the more we give, the more risk there is for late complications and interactions for this in these treatments. Here is a study on the risk of cerebrovascular disease in the British childhood cancer survivor study. And by age 65, as many as 1 in 4 would have been hospitalized for a cerebrovascular event, as you will see in the coming grades and graphs. And this is important because you should then be monitored for all the other things, comorbidities that may increase your risk of cardiovascular problems like hypertension, dyslipidemia, diabetes, obesity, etc. And here is a graph showing this, that at the age of 60, 65 years, 1 in 4 of those CNS tumors that were irradiated have developed a cerebrovascular event, compared to 6.5% of those CNS tumors that did not receive radiotherapy. And the leukemias that we, in the 70s and 80s, gave prophylactic radiotherapy to the CNS and sometimes to the cerebrospinal system as well, to reduce the risk of recurrence in the central nervous system, also has an increased risk, but a lot lower because the doses were 18 to 24 gray, which is less than what you receive for a brain tumor. It's important to know that what we do and what kind of follow-up that we offer to our survivors is something that is an evolving field all the time, and it needs to be investigated and improved. And this is a good example of that with Lieke from Holland and colleagues showed that there are differences in the risk of cardiomyopathy depending on which anthracycline you received in your treatment. And this is a new recommendation which could show that, for instance, mitoxantrone, which we use in AML, increases the risk, is 10 times the dose of doxorubicin when we want to have doxorubicin equivalent doses, compared to what we said before, which was 4 to 1. And so it's important that all these studies are done so that we can constantly upgrade and update our knowledge and give the best recommendations possible. The adult life after childhood cancer in Scandinavia, Alex, is showing research coming from the 5 Nordic countries, and this is the basic description of the study. There have been several papers in this, but I will show you a couple of them. And this shows the hospital admission rates for neurological disorders among 5-year survivors of non-CNS tumors in childhood. And you can see that compared to controls, there is a higher risk for neurologic disorders, especially within the first decade of life. So it's those that are non-central nervous system tumors and still get these neurologic complications. Recently, there was a publication on skeletal adverse events in the Alex study. And you can see that it's a bit difficult perhaps to see, but you can see that the patients here, compared to the comparison subjects, have an increased risk of all these issues. Here are all skeletal disorders. Here you have osteonecrosis with the top early on, which we can see it's mostly in the weight-bearing joints, more often in girls and more often affecting those that were treated in adolescence. But for all these osteoporosis, fractures, etc., there is, apart from maybe osteoarthrosis, there is an increased risk for those that had cancer as a child. This is an update of the first Richard statement, which came in 2006, which was revised when we went to Erice in Italy 5 years ago. And all this, what this update shows is that it's still important to have these aims and goals that we find are essential for the survivor's cure and care. And it's the 10 that are listed here, which is cure, care, communication of risk, which again comes back to what Anna was speaking about and a lot of the discussion was before. There must be a systematic follow-up. There must be a research agenda so we can improve things over time. Empowerment, which means that our survivors should be well-informed, well-supported so that they feel that they can tackle a lot of these issues on their own, not completely on their own, but in day-to-day life. And there should be a risk, an update on the risk of developing medical conditions, which should involve the entire family and sometimes even those that are not just the entire family, but it affects many different aspects of family and friends. Then again, we need to inform the general public that this is available, this is something that happens. And not only the general public, but healthcare systems need to be aware of this, that this is an issue. This is really a moral obligation. If we give tough treatments to children and adolescents, we have a moral obligation to take care of them when they grow older and support them in any way possible. So what could we do possibly to prevent these things from happening? There's, of course, primary prevention that avoid or reduce exposure in the first place. And that has happened in several ways where we, for instance, for Hodgkin lymphoma, we give lower doses of radiotherapy. We give small radiotherapy to smaller fields in order to reduce the exposure and thereby reduce the risk for late complications. And analysis of the host genome will most likely tell us which patients are at risk for a specific toxicity or complication. But then the issue is what you exchange the treatment that you are now not going to give. What is the new drug that you will give? For instance, if you take away doxorubicin and you still want to keep the good survival rate, what do you give instead? And that's not obvious. And then there could be a parallel prevention when you give treatment, for instance, Cardiomyopathy, dexrazoxide to prevent cardiac toxicity from anthracyclines, which I will show some data on later on, and sodium thiosulfate to prevent ototoxicity from cisplatin. So there are increasing evidence that dexrazoxide could give good cardiac protection without reducing the efficacy of the drugs. That means maintaining the same cure rate. But unfortunately, we're not using this, at least not in Sweden. I think in many different places in Europe, we are not using it. And where we give high doses of anthracyclines, for instance, the bone sarcomas, I think we should seriously consider that our treatments need to have dexrazoxide up front. At least it should be given, I think, when you come up to a certain cumulative dose of the anthracycline. Here again, more information on the safety of dexrazoxane, that there were no effects on the, there were significant worse effects in cardiac function in the group that did not receive dexrazoxane as a cardioprotectant. But the event-free survival was not affected in that group. And there were issues when this was first discussed I think around 10 years ago, that dexrazoxane increased the risk of second malignancies. But this group from the Children's Oncology group in North America could see that there were no associations between dexrazoxane and deaths due to either AML, MDS, or cardiovascular events. So there doesn't seem to be an issue of increased rate of second malignancies. And here is from a couple of years ago, showing that if you give sodium thiosulfate after cisplatin chemotherapy, there's a lower incidence of cisplatin-induced hearing loss and this was shown among children with standard risk hepatoblastoma, and still the event-free survival at 3 years was not affected by it. And hepatoblastoma is a disease that affects mostly younger children, and if you give them these high doses of cisplatin, you can also see that if we affect the hearing aid of somebody who's maybe 2-3 years old, that will be a big issue for their future life. So that's a brief overview, and I'm happy to take any questions.
Lars, thank you very much. Great task in 45 minutes. Questions for Lars?
I think this is something we see who do these lectures and give these lectures, that it's usually quite quiet after the end of our presentations, that it's a tough and hard message to get, and it leaves people with more reflections and not so many questions, I think, a lot of the time.
But Ricardo stepped in, so please, Ricardo.
Just to thanks to Lars for this very comprehensive presentation. I try to be provocative just to make asking discussions. So I have two questions. One is about this. So let's call it, if you allow me, sort of game of doctors looking for problems. Okay. So for example, when there is a paper saying that 1 out of 4 survivors has a cerebrovascular complication, that is a very strong, maybe also impressive information. But then when you look at the data, there is only a particular subgroup of survivors who had that problem, which contributed to these statistics. The other 80% of survivors, they do not have that problem. So it again is a full empty or full half empty or half full glass we are talking about. So I think we need also always to show the differences, just not to say everything is bad or everything is good. But I think the information and the communication should be a little bit more specific. That takes much more time. That is difficult to communicate, but I think that's an important thing.
Yeah.
And
so you're perfectly right that the nuances of this are important to get across. And again, I think coming back to Anna's presentation and the discussion after that, we need to give, when we know that there's a high risk of problem, we need to be very upfront and early on in primary treatment, mention that this will most likely have a price.
Yeah.
And at the same time, it's important because people read, parents read, and teenagers read, that we can tell those that we think there will be low risks of complications. The same thing, that for you, I don't think there will be an issue. For instance, if you give a standard risk leukemia treatment, the risk of infertility, I think, is very, very low. And if somebody has issues about that and thinking that, oh, I will not be able to get, may not be able to get children when I get older, they should be informed of that your risk for that is, it's of course not zero, but it's quite low compared to if you give a treatment that's much more likely to give fertility issues.
And the other question is about being you involved, I know, in mostly in treating sarcomas and so on. Do you think, so there are two sides of the question, say, what is the role of late effects expert in designing frontline therapies? And if, and the other issue is, do you think we are ready for primary prevention you were mentioning? So do you think we might be ready sometimes to do a randomized trial to test doxorubicin versus another drug and see, ethically speaking, and see if the effect is the same?
Starting with the second question, I think that will happen, but it will happen, I would guess, for those with really poor prognosis. So that if you want to do something innovative, you will most likely do it with metastatic disease or those where you have low chances of doing something. So you would introduce a different drug maybe in that group first, I think. And coming back to your first question, we are now setting up a Europe-wide osteosarcoma consortium led by Nathalie Gaspard in Paris. And my hope, and there are different work packages in this, one is on quality of survival and late complications. And my hope is that we can play an important role in having late effects issues upfront when we come up with a new osteosarcoma protocol. We're all relying on the EUROMAS-1 protocol, which it's over 20 years ago since the idea of that first started happening. And we need urgently new and better treatments for bone sarcomas. And of course, late effects should be there upfront and finding out the endpoints and including the endpoints so that we don't stop looking at these patients just because it's gone 5 years after treatment and we're done with the study and we put it on the shelf and we start the new study. It should be continuously followed for a long, long time, I think.
Thank you, Lars. Good point. Menya, please.
Hi again. Thank you, Lars. I'm not a healthcare professional. I am a parent that reads all these studies and all this data. And don't have a question. I just want to share with all you my feeling after the presentation of Lars is a question that can we blame all these late effects and all these data and all these statistics because we don't have new treatments and new drugs for our kids? Is all these late effects caused by all these treatments and the started treatment the kids are having? This is my thought when I read and hear all these statistics about the late effects. As a parent, I'm keep asking myself, is all this happening because of the treatment our kids are having? I don't know, wait, I don't want an answer. I don't know if the science has an answer, but I just want to share with all you my thoughts. Thank you.
I think it's an important issue, Mania, because you can't blame everything always on the treatment that was given. But it's also hard to dispute when you see these issues compared to the general population or to sibling controls, for instance, in the North American studies, that there is a connection with the treatment for many of the things, but of course not for all of them.
Thank you. Any other questions or comments? Myra Vela, please.
Hi, hi Lars, thank you very much. I just want to ask a question about the cardioxane and the sodium thiosulfate. Are there any centers, big centers, that are actually using this already? I've used cardioxane as a sort of in a patient who had already some cardiotoxicity, and then we had to give further doxorubicin. But are there centers, any big centers that are using it first line?
Not that I know of. I know that they do it in North America. I'm not aware of everything going on in primary treatment all over Europe. There might be places where it's used. I think I'm tempted to use it if we have, for instance, an osteosarcoma, which is going to get 450 milligrams per square meter of doxorubicin, which we know is a high dose. And if we tomorrow get a standard risk hepatoblastoma, I would argue with my colleagues that we should give this child sodium thiosulfate, as was done in the study.
So perhaps, Lars, this is Leontine. I can add a little bit because it's important to know that we are developing a global guideline on dexroxane. And I think it will be published in the first half year of this year. So then we will have some evidence, summaries, and also the recommendations. I expect we will not give a very clear answer, but I can see what Lars is saying, that if you have a very high dose of doxorubicin, that you can give dexroxane, but not to all patients. That will be in a short summary and highlight of the recommendations, I think.
And there are mentionings in the chat now that in the UK, in several places, it's used. So I think it's.
Yeah, but
I guess every center, every country need to think carefully about it, because if we can prevent cardiotoxicity, I think that's a big step forward.
Yeah, but use the good evidence, and I think that will be important to have the overall overview. So yeah, that's the link when we have the guideline finalized.
My understanding is that recently, only a few years ago, EMA accepted again, speaking of dexroxane, to be used as a protective during treatment. But in the EMA recommendation is just after, as Lars was mentioning, just after having received, I don't remember, it's 200 or 250 milligrams. Because the issues were at the beginning that dexroxane might decrease the effect of anti-cancer treatment and increase the possibility of secondary cancers. The same is also for sodium thiosulfate. I'm a little bit involved in the neuroblastoma thing. And for example, also in the neuroblastoma group, they are not recommending providing sodium thiosulfate to patients treated for neuroblastoma, again, because there is some sort of concern of the possibility of antiblastic effect. What we are doing now in Italy is just to make a sort of recommendations, more or less, suggesting to use speaking of dexroxane, to use dexroxane to survivors who are. We are actually suggesting to plan to give it even before reaching the 250, in particular to those patients we know they will receive in any case higher doses. Another issue was the fight with the pharmacy, because at the beginning the dexroxane was a little bit expensive, so there was a discussion with the pharmacies to justify the use of dextrosane. Now the cost has been reduced in a significant way, so I think that is worthwhile doing it. So just to answer your question, in Italy there are a few centers that are using.
And it's like was just mentioned in the chat also, we've always said that bolus of anthracyclines are more dangerous than longer infusions. And if you give dexazoxane, we're going to have to give, if I remember correctly, anthracyclines as a push. So you will give dexazoxane and then anthracyclines as a push, which is counterintuitive to us who have always said that we can't give bolus doses of anthracyclines. So it's a mind frame and mind shift also if we decide to do it, that you need to trust the data and you need to trust that doing it in that way will be not worse for efficacy and better for the long term.
Yeah, that goes back to my question to you, Lars, if we can do randomized studies. So let's say next leukemia protocol, dextrosane versus not dextrosane.
I hope this could be introduced in the osteosarcoma protocol that will come in a couple of years. That would be something I would really hope.
Yeah, that would be really nice, because I think we have already evidence from leukemia from the US, but we have no evidence about osteosarcoma. So that
and those doses are much higher than we give our leukemia patients, except for the AML, which receive mitoxantrone.
And mitoxantrone, we do the same in the Netherlands. We use it there, but I think there is no evidence at all. So we have a debate there going on, because we don't know if it's really helpful. So I think we should be careful with dextroxane, but also use it for these severe patients. That will be the future, I think.
Thank you very much. Also, Pramanyam, your hand is up. Please go ahead.
Good morning. Thank you, Lars, for the insightful presentation. There was a brief mention about the equivalent dose of mitoxantrone, which is now not 4 times, but 8 to 10 times. So going forward, do you think that will be the conversion ratio that should be used when we calculate the cumulative dose of anthracyclines?
I think so. I think maybe Leontine knows that better than I do, but I think what Lieke and colleagues showed is that the old conversion data were, I think, mostly when you looked at bone marrow toxicity, that the equivalence was sort of what you get in bone marrow toxicity should then be the same as the risk of cardiac infection. But now I think Lieke showed that this is more strict for the cardiac function, and then the factor went from 4 to 10. So I think it's and that's a big improvement, because that's added knowledge to give us better information on the risk. So I think that's, we use the new conversion also. So you can for instance, you can go daunorubicin. It's the opposite. You now have a lower conversion factor for daunorubicin than what you had for in the earlier.
That's exactly my next question. So previously it was 0.8, but now it is 0.5, isn't it?
0.6, I think, or something like that. But it's less. So daunorubicin went one way, and mitoxantrone went quite the opposite way.
Yeah, I agree, Lars, and I think it's the best evidence that we can get, because it was including all the big studies of the world. So we will not get better evidence, and it's impressive. And I can see that, I'm really happy that it's mentioned here, because I can see that pediatric oncologists have a big difficulty with it, in accepting it, because it's broad used in Europe. So we should be aware of the risk of clinical heart failure in this group.